So, kia ora everyone. Welcome to today's webinar with Linda Kirkpatrick, who's from the New Zealand Policy Research Institute here at AUT and completing her PhD at the same time. And she's going to talk to us about examining the well-being impacts of urban regeneration using administrative data. And being Linda's primary supervisor, I must say to everyone that if you've got any suggestions for her research, make sure you phrase them as things that she should consider post-PhD, because she's been very explicit to both all her supervisors that she doesn't want any more tasks to do during her PhD. But really looking forward to the discussion and the suggestions people have. And also, if you've got any questions, keep them to the end, please. Otherwise, if they're clarification ones, then raise your hand and ask during the presentation. But otherwise, over to you, Linda. Thank you.
Thanks, Gail. So as Gail already discussed, this is my PhD topic. It's very, very close to finishing. I'm shy a few months away. So if there are any suggestions, like I'm spiritually done with this PhD, so I don't want to do any more analysis, but I'm happy for any suggestions for something to do later on. So starting off, I'm looking at the wellbeing impacts of urban regeneration using administrative data, and I'll just talk through. I'll start with talking through some of what urban regeneration is. I'll talk about what we find in the literature about urban regeneration and well-being. Talk about the data that I use, which is housing intensification data from Kāinga Ora, and the model I use to measure well-being and urban regeneration. Talk about some of my results, and then I'll conclude. So there are a lot of words in my title, so I thought to get everyone up to speed with what I'm actually doing, first, I'll talk about what is urban regeneration. And this leads me to the why. Why do we care about urban regeneration? What is its relevance in New Zealand? Why do we want to measure the wellbeing impacts of urban regeneration? And I'll also talk about some of the wellbeing frameworks I'll be drawing from. And then I'll discuss how I measure the wellbeing outcomes using administrative data from the IDI, or the integrated data infrastructure, and the methods I use in my analysis. And as a result, this helps ensure that current and future urban regeneration developments in New Zealand are guided by empirical evidence. So rather than tell you what urban regeneration is, I thought it would be easier to show you. So urban regeneration can look like increasing the housing supply by building multi-unit dwellings like townhouses and apartments. It could also look like neighborhood improvements, so better street lighting, better road conditions. It can also be revitalizing town centers, expanding retail opportunities. It could also be improving the existing housing stock, so refurbishing old homes or improving heating and insulation. It's also redesigning spaces for walkability and cycling. And it can also be improving public transport linkages and roading infrastructure. It's creating public and green spaces such as playgrounds and parks for the public to enjoy. It can also include non-physical initiatives such as employment and training hubs to upskill residents. It can also be engaging and involving the community in the physical urban regeneration process to better understand community needs. So, Kāinga Ora is the government agency responsible for social housing and urban development in New Zealand. And one of its initiatives is to increase the supply of public and private housing through intensification. And this is the main policy tool used by the government to drive its future housing initiatives. As of 2018, KO has built nearly 10,000 new homes, with the majority of this being social housing. And according to its annual report, in 2022, it invested $2.3 billion into upgrading and building new homes. And KO plans to build 30,000 to 35,000 new homes in the next 10 to 15 years. And half of this is expected to be built in Auckland. However, with the new government and budget cuts, this may also change. I know there's some Kāinga Ora people in this call, so they could probably give me some insight into that. So this is it. This is an example of housing intensification in Glen Innes in Auckland. So this is where one or two single dwellings were replaced with several multi-unit dwellings. So the physical environment in which people live can affect their health and well-being. And so by regenerating urban areas that people live in, we have the potential to improve health and societal outcomes. And so alongside housing intensification and neighborhood improvements, some studies looked at urban regeneration schemes that included the community-based employment and training hubs, and these were aimed to increase labor force participation. Other initiatives included teaching and tutoring services for students to improve their test scores and educational attainment. And urban regeneration can also drive the demand for new schools from population growth. With respects to mental health, some studies looked at how improving the quality of existing housing stock could improve people's physical health. And warm and well-insulated homes can reduce respiratory illnesses and reduce sickness that limits the ability to work. Some studies also hypothesize that urban regeneration can promote healthier behaviors, so green spaces and these neighborhoods which are designed for walkability, as well as having high density living, closer to amenities. It encourages people to walk more, cycle, take public transport, so these more active transport options, and these have the potential to improve respiratory and cardiovascular health. And living in high quality homes and neighborhoods may also improve people's sense of belonging and pride in their home, and thereby improving their mental health as well. And with respects to crime and safety, so improved street lighting can make neighborhoods feel safer. High density can mean more people living in one area, which promotes natural surveillance from just having more people around and improving those feelings of safety. And so there's also other interventions that high police security and neighborhood warden schemes, and that can reduce the overall rates of crime. However, the literature shows that the impact of urban regeneration on wellbeing outcomes is mixed. So for example, some reports have really positive health impacts from improved walkability and having public transport infrastructure, while other studies found negative or no impact of urban regeneration on health at all. However, where the studies did find positive effects, there was a strong association between urban regeneration and the potential to improve wellbeing outcomes. So there's no strong consensus for the direction of urban regeneration on wellbeing. Additionally, most of these studies are observational, descriptive, or qualitative in nature, and where data is used, the data is cross-sectional. And so when they did use data, it was like a subset of the population, so it's usually done with survey data. And so urban regeneration tends to be these large-scale projects that can span large geographical areas in the neighborhood. And so with the current literature, there is limited evidence between urban regeneration and well-being, especially seeing how different populations are impacted by it. And so this leads me to my own research. So there is potential to use administrative data to measure the well-being impacts that have not yet been fully explored in the literature. And so my research provides a framework that uses administrative data to measure population-wide well-being indicators across human capital, physical and mental health, and crime and safety. And so I use this framework to evaluate the short to medium term wellbeing impacts of urban regeneration in New Zealand. So wellbeing can mean different things to different people. And so luckily for me, the Treasury already devised a wellbeing framework called the Living Standards Framework, and this makes this task a lot easier. And so the primary purpose of the LSF is to be used as a policy to allow the government to understand the drivers of well-being in a systematic and evidenced way. And so the LSF comprises of 3 levels, and my research draws on that first level, which is individual and collective well-being. So as you may already know that there is an LSF dashboard, which provides well-being data at the nationwide level. However, the data mostly uses surveys, such as the Household Labour Force Survey. This is collected every 3 months on about 15,000 households. There's also the General Social Survey, which is collected on 12,000 individuals every 2 years. And so indicators in the LSF are only available as often as survey data is available and only available for a small subset of the population. The other wellbeing framework I draw on is the index of multiple deprivation. And so by design, the IMD measures area level deprivation in New Zealand using admin data. And seeing as this is the Virtual Health Information Network, you guys probably already know what the IDI is, but I'll quickly run through it. So my research uses administrative data from the IDI, which is a centralized collection of data sets that cover the New Zealand population. I can link individuals across data sets from different sectors, such as health and earnings, and there are pros and cons to using the IDI. The pros, which I've listed above, so things like high population coverage, linkages, but the main limitation in using the IDI, at least for the purposes of my research, is that it's collected for administrative purposes. And so the variables that are available to me in research are often proxies for more subjective variables. So I can't measure the subjective feeling of safety, but I can measure the actual incidence of reported crimes. And so behold my wellbeing outcomes framework. So this framework is designed to measure monthly population-wide wellbeing using data from the IDI. So I've grouped this across 3 domains. So there's human capital, physical and mental health, and crime and safety. And so where the existing LSF or the IMD uses admin data at the population level, I continue to use the same indicator. And where the LSF cannot be measured with admin data, I use proxy variables. So you can all read this, let's quickly go through. So under human capital, there's education, so that's secondary and tertiary educational attainment of the adult population. There's youth NEET rates, so not in employment, education, or training. In terms of the labour market, I'm interested in the employment rate, their earnings, benefit recipiency. In terms of physical and mental health, that's emergency department admissions, cardiovascular disease-related hospitalizations, respiratory-related hospitalizations, and for mental health, that's mental health service access. I've actually renamed that to mental health utilization and self-harm events. With respect to crime and safety, those are victimization rates of these different offences. And for safety, it's accidents and injuries related to work, home, and road. And so to create my human capital wellbeing indicators, I use several different data sets from MOE, inland revenue, and MSD. So I've just listed them here. I made these really pretty graphs, and they haven't made I was told to take them out of my PhD for space, so I wanted to use them somewhere, and this is where they've ended up. In terms of physical and mental health outcomes, those are mainly from MOH, MSD, ACC, and Oranga Tamariki. And for my crime and safety outcomes, this is from New Zealand pre-count victimizations and ACC claims. So one of the key features of my research is detailed monthly housing intensification data provided by Kāinga Ora. So I have this monthly pipeline data, which spans from 2018 to 2021, and this shows current and future housing projects in New Zealand. In the data, it shows the expected number of dwellings to be built, where it's going to be built, and what month they begin to build it. So this is not when the first shovel goes into the ground, but when they've told the neighbors, they've told the residents, there's financial commitment to building. The data available is at the mesh block level, but for my analysis, I aggregated this up to SA2 level. So mesh blocks are the smallest geographic unit, which contains 100 to 200 people, but I aggregate this up to SA2, which is about 1,000 to 3,000 individuals. And so I chose SA2 because urban regeneration are these large projects, and so there's likely to be a lot of spillover effects on not just residents who move into these developments, but those that also live in that surrounding neighborhood. So by just creating a bigger, geographic catchment, that was my reasoning for why I wanted to do just these big neighborhoods. So some descriptive statistics about urban regeneration. So almost half of CARE's urban regeneration program, Auckland based, So 70% of homes are expected to be built in Auckland. As I'm interested in the treatment effect of urban regeneration, it was important to me to exclude Auckland suburbs where there was already some pre-treatment in the past. And so therefore, if I had some data where there was some building between 2005 to 2017, these were considered pre-treated, and so I excluded them from my treatment group. I use the mesh block data to identify which SA2s undergo urban regeneration and which SA2s don't. And then after exclusions, there are just over 3,000 homes expected to be built in Auckland. So that's about a quarter of that 15,000 that I started off with. So I learned how to do some GIS over the course of my PhD. So this is just me showing off my map building skills. And so this is just a geographical representation of where urban regeneration is dispersed throughout Auckland. So the gray areas are pre-treated, the blue control, and the green areas are varying shades which represent like the intensity of urban regeneration in those areas. And those are the treated areas. So we've got some labels. So at the bottom there, we've got Drury, which is like really dark green, but going in Glendowie, Kanini, Glenfield, just so you can kind of see where it's all going on. Here we have the type of housing being built of the expected dwellings, so those 3,000 odd homes. The overwhelming majority built is social housing, which makes up about 80%. Secondly, there's Kiwi build or affordable housing. So these are homes sold under market price. These make up about 10% of the dwellings. There's transitional or emergency housing, which makes up 7.5%, and then 2.4% of the remaining dwellings are market, which are just houses sold to the general at market price. So the data available measures only housing intensification. So the urban regeneration initiatives I showed earlier in that first section are part and parcel of Kāinga Ora-led urban regeneration. So they are occurring at the same time as housing intensification, but they cannot be disentangled in the data. So to form my sample, I start with individuals who are active in the IDI each year between 2015 to 2021, where 2015 to 2017 is my pre-treatment period, and treatment starts sometime between 2018 to 2021. Second, using address data from the IDI, identify which individuals are living in treated versus control areas for each month between 2015 to 2021. I attach a bunch of demographic information to the individuals, and then I summarize this into monthly SA2 observations. So putting it all together, my research measures the wellbeing impacts of urban regeneration using administrative data. I've got some frameworks, got some data, and measuring the wellbeing impacts across these domains. So I know there's a lot on these next few slides, but just do bear with me. I'm going to keep it to a minimum. So to estimate the wellbeing impacts of urban regeneration, I used a staggered difference and differences model, specifically the one from Sun and Abraham. So treatment is staggered in my data. Urban regeneration can start anytime between 2018 to 2021. And so I'll just quickly summarize the equations. So wellbeing outcomes are estimated incorporating SA2 and time fixed effects, timing of urban regeneration, and SA2 specific covariates that vary across time, such as household size, ethnicity, gender, age, and partnered composition. This is mainly just to show you that I'm an economist and I can make some, do some equations. But you can, if you want to know more about this, you can read my 200+ page thesis at the end. So this delta here is the DID estimate of interest, and this estimates the causal difference in wellbeing outcomes between treated and control areas for each cohort and their relative time periods. Sounds pretty gross, but that's what I'm interested in. And so if urban regeneration increases educational attainment in treated areas compared to control areas, this delta will be positive and statistically significant. So as control and treated SA2s have different demographic compositions, control SA2s are weighted to treated SA2s in that pre-treatment period, so between 2015 to 2017, And these are across demographic characteristics that I listed in the previous slide. So I run these equations separately for different urban regeneration intensities, as well as social housing status. I also ran this at the SA1 level, but the effects were not that qualitatively different to the SA2 results. So it's more like a robustness check to see if there was like more localized effects compared to aggregate area effects. It is important to note here that I am estimating the short-term well-being impacts of urban regeneration. Time has physically not elapsed yet for me to be able to estimate the longer-term well-being impacts of urban regeneration. And secondly, the impacts are likely to be underestimated due to two reasons. So first, 3/4 of the Auckland dwellings are being built in pre-treated areas. So my research had to exclude these from the analysis. And secondly, urban regeneration, so urban development, can take a long time. And so by the end of my analysis, which is December 2021, treatment has not yet finished. And so I can't observe the full treatment effects. So on to the results. So I ran some regressions, and then I ran some more regressions. I ran so many regressions, and this was not even remotely close to all of it. So we know that treated areas are building more homes. However, there is no significant difference in the number of dwellings in treated areas compared to control areas, irrespective of urban regeneration intensity. So this suggests that like urban regeneration is going on in treated areas. There's also urban development going on in control areas as well, which is not led by KO. So there's private developers, which is why we probably don't see any statistically significant difference here. With respects to social housing, we see that treated areas are building significantly more social housing compared to control areas. And this is unsurprising because if there was social housing built in control areas, there would probably cease to be control areas, and this would be part of my treated pool. And so we see this is happening predominantly in low UR areas. So while we do see some first order effects in treated areas, the increases are economically small. So this goes back to what I previously mentioned, that treatment is still ongoing. And so we're not seeing the full first order effects at this stage. When we look at the population numbers, these are similar to that of dwellings. So we see there is no statistically significant difference in population size between treated and control areas, and the social housing population grew in like low UR areas. So again, while this is statistically significant, the increase is economically small. So armed with these very modest first order effects of urban regeneration, to which I've dedicated 3 years of my life so far, you can probably imagine what the area level wellbeing impacts of urban regeneration are. Not much happens. So at the aggregate level, there doesn't seem to be much impact on well-being. However, even if non-significant, does it at least look like they're starting to improve over time? Or are they getting worse? Are well-being outcomes for the social housing population improving, but gets lost when we look at just the overall population? So my area level regressions compare social housing and non-social housing to the full control group. And yes, I know what you're thinking. Obviously, social housing are going to have worse outcomes, so wouldn't it be better to compare social housing in treated areas versus social housing in control areas? So I do this in my individual level analysis, which I don't cover in this presentation, and that analysis compares apples to apples, so social housing to social housing, non-social housing to non-social housing, so on. However, for the area level analysis, I was interested in seeing how wellbeing outcomes changed over time for social housing and non-social housing when compared to the same control group. So I wanted to be able to compare those different urban regeneration intensities against the same group. So for a lot of my wellbeing indicators, we get graphs like this, where we see absolutely nothing happens. However, it doesn't look like they're getting worse either. However, some of it does get worse. So the proportion of the treated population with tertiary attainment was significantly lower compared to the control group. So it does start to look like it's improving at the end there, but so far those are non-significant. And some things do appear to be getting better. So median wages and salary for women in treated areas increased over time compared to those in control areas. This is also a plug for my poster, which had won a prize at NZAE. You can find it on my LinkedIn. It's a very beautiful poster. So given that there's attitude of this not in my backyard when it comes to social housing development, I found that the non-social housing population didn't appear to be negatively impacted by increased social housing development. So compared to control areas, there was no statistically significant difference in the assault victimization rate, nor the theft victimization rate, or robbery victimization. So this isn't to say that these things don't happen. The graphs do show a non-zero victimization amount, but these are not significantly different to those living in control areas. We also don't see it via increases in mental health utilization. So when we look at just social housing, we see that social housing tenants have significantly higher victimization rates compared to control areas. So those who are already a vulnerable population before urban regeneration still remain a vulnerable population. So note that I only compared the area level stuff, and I'm very, very close to finishing my individual level analysis. But I've also been allocated like a short period of time for this presentation, so I can't go through all of it. But looking at some of the graphs, you may think, well, yeah, median income could be increasing because new people are moving in who probably make more money, or a treated area is becoming nicer and more expensive. And so those who would have worse outcomes are getting priced out and moving away. Or it could be the opposite, where people may leave areas undergoing urban regeneration just because there's a lot of disruption going on, or because there's a lot more social housing development and they left and took their better outcomes with them. Or maybe it's long-term residents of these treated areas who lived there before urban regeneration and they're reaping the benefits of urban regeneration. So we know social housing tenants are moving in from the first order effects, but what do the leavers and newcomers moving in and out of these areas, what do they look like in terms of their demographic characteristics and outcome? And so this is the next tranche of my analysis, is to look at this group of individuals who move in, move out, remain, and understand how urban regeneration may impact different subpopulations. So concluding remarks. So the first order effects are modest. So this may be due to the fact that treatment is not yet complete. A lot of areas were excluded due to pre-treatment, and not enough time has passed to be able to assess longer-term effects of urban regeneration. And so, unsurprisingly, this also showed mostly non-significant results. We don't see much going on for non-social housing, which may be a good thing. However, social housing doesn't appear to be improving either. So a vulnerable population is still doing worse compared to the general populace. And the next and final steps of this journey for me will end at the individual level analysis, which has presented many computational challenges in the data lab. So hopefully the individual level analysis will contribute to understanding how wellbeing impacts are distributed among subpopulations. And finally, when I'm done in a few months, please feel free to read my 200+ page thesis. I was just working on it today. It's at 220 now. And it's probably going to grow a little bit, and if you're curious to see how it all pans out. And thank you. That concludes my presentation. Thank you for coming along. So I will now open the floor to any questions, and also suggestions for analysis after my PhD. Very, very important that it's after my PhD is submitted.
Thank you, Linda. I'll ask the first one maybe to kick us off. It's quite a broad one, but in your analysis, obviously you're focusing on short term because of the data you have and the time period that you're able to look at. Is there any indication in the literature of what is a appropriate time frame to look at for these, where you might see effects of urban regeneration or housing intensification more specifically?
That is a good question, and the literature. So there isn't like an appropriate time frame, but the similar literature that has looked at urban regeneration projects have like at least a 10-year view, and they also find nothing happens as well. So I don't know if that's because even more time needs to elapse, or that those really big area level projects might not impact wellbeing the way we think it does.
Oh, thank you. Well, there's one in the chat. What were the analysis limitations you faced in the data lab with the individual analysis? I'm sure Linda would love to answer that.
Yes, so it was not the case where I didn't have enough observations. It was actually the opposite where I had too many. And if you're running a staggered DID, for anyone who has run or hasn't run it, you need to there's like a lot of different effects that need to be calculated at each time point. And so the matrix that you need grows exponentially with more data points, like either through people or time. And so every time I try to run it, like it will just like crap out and I couldn't. And so I've had to think of very creative ways to try to overcome that. And so what I had to do recently was just really look at different literature that also does staggered DID that runs much faster. So my goal was to find not the methodology, but a package that would run fast enough and strong enough to give me what I want. I hope that answers your question.
Thank you.
Kia ora, Linda. Kyle here from Auckland Council. I'm not a health researcher. I was just interested to hear what you're doing in terms of urban regeneration, which is my interest. You went through a whole lot of stuff, and I had a lot of questions as you were going through, and you addressed most of them. And I guess my question was, in terms of social housing outcomes, I guess one of the benefits is that we're finding that you're not making things worse, which is a positive thing, right? And I guess in the back of my mind, though, I guess urban regeneration is not just KO, and you said it's also not just housing, and it's widespread across Auckland in particular. And so I guess it's, in my mind, potentially unsurprising that you weren't able to distinguish outcomes there, because there's a lot of change for everybody going on too, and especially for those people in the social housing, which KO is currently making. So I guess my question was, in terms of rental changes, in terms of the economic benefit of social housing over others, was that something that you're able to be picking up, or was it because the tenants in the social housing that you're looking at mostly were already probably paying social housing rent in other locations?
Yeah. Okay. All right, nice to meet you, Kyle. I'm glad I'm not a health researcher either. I'm just a humble econometrician. With respects to the social housing, I think you're asking about rents. So rents was a question I got a few times, not just this year when I presented, but last year as well. And I think, and so we didn't look at it for a number of reasons, but one, the rental prices we felt could be conflated with urban regeneration as areas get developed more and they become nicer, you might just see like a rental increase. And so that it would be hard to disentangle that from the data. And for me as well, I think rental prices or housing prices are one of the things that tend to get measured quite often in these projects. And so I wanted to focus more on like a well-being lens, because I know there are other papers that look at things like rental price changes and housing price changes. And I wasn't sure if I could add that much more to that space.
Fair enough. Thank you.
Thanks, Carl. Linda, there's a question from Barry about whether there are any parts of the country you could have focused on where regeneration has been completed and there are 5 to 10 years of follow-up data.
So the data that was available to me was this Kāinga Ora 2018 to 2021 pipeline, and they did provide me with other data that gave me some pre-treatment, to identify where pre-treatment was. The problem was I didn't have one, it wasn't comprehensive. And so if I went back in time from 2005 to 2017, I could identify some areas that were being treated, but I wouldn't be able. So if I could only identify some, and I'm looking at these big geographical units, it'd be hard for me to tell whether or not they were would be actually control groups with that missing data. And so it was mainly more like a data limitation. It was good enough for me to exclude pre-treated, but not good enough that I could use it as a to look at the treated outcomes. Unless it was like a simple like regression to time points.
Yeah. I think the availability of the data makes a real difference, and it also illustrates to the provider the importance of that data record keeping and ensuring data quality, not just for themselves but also for research purposes to evaluate outcomes. There's another question. Given the time period of your analysis, what impact do you think COVID may have had on your results?
So I think when I looked at my descriptives and looked at the different wellbeing outcomes, and this is a really good question, they follow the same trend. So it didn't seem like there was if there were uneven distributions and descriptors over time, I think that would have been a cause for concern. If you're talking about the within groups, and where COVID had probably had the most impact was on like health-related indicators, because obviously a lot of healthcare wasn't available. But the fact that if it's just everyone looks like they were impacted similarly, so the treatment impacts could be muted for sure, but it's not it doesn't appear to be uneven. Hope that answers your question, Sam.
And when you're starting off, you're saying that you were using KO's sort of intended pipeline. Did you have any data in terms of like when these actual houses were being constructed and the difference between like people actually living in these new houses versus in some other house in the general area?
Good question. Yes, but it was not good quality, as in it was inconsistent when like in the data, and so I didn't want to use that measure, like the temporal measure, because I couldn't trust that it would be reflective of when treatment finishes. But I knew that the amount they were building, this was confirmed that whatever they set out to build, they were building, but the time frame and when that was actually completed wasn't definitive. And which is why I use a static rather than a dynamic measure. That was a really good question.
Yeah. So I guess in terms of thinking about the results, it's more about how is this building project affecting the neighborhood as a whole rather than individuals within it?
Yes, yeah. And so I think naturally when you are looking at the short-term impacts, there's going to be some that's completed, a lot that isn't, and that just, so I emphasize a lot of the short-term impacts, and hopefully I can run this in another like 5 to 10 years time, and when things are hopefully completed, and then when we measure that, it's starting to look more like the treatment effects, full treatment effects.
Yeah, just a follow-up comment more than a question. In terms of the levers and incomers and stuff like that, I know with the large-scale projects that there was a lot of, I guess, community disruption as they moved a lot of people out to other places. And it'll be really interesting to see whether it's those same people that are coming back or actually they've become more attached to their new location and they're coming back to the same location, but it's not the same place anymore, and how that sort of works over time as well.
Right, so like a leaver and simultaneously a newcomer.
Well, I think there'll be quite a gap between them as, KO, moves everybody out. 2 years later, there's a bunch of new houses. Some new people start to dribble back in, and it might be some of the same people, but it's possibly that they're not, because after you've been living in a new place for a couple of years, do you want to uproot everything and come back? Will it be and even if you did that, it's the same street, same address potentially, but is it the same place in terms of how it's been, completely rebuilt, and the landscape is quite different as well.
Useful comment. Thanks, Kyle. This is a time where we all virtually thank Linda for her presentation. Thank you, Linda, for telling us about what you've been doing on your PhD.
Yes, thank you for coming along.
And if you have any questions, feel free to email her. I'm sure she would look forward to some suggestions post PhD. Thank you, everyone.